The purpose of this video is to examine the concept of mobility as it relates to the exemplars of fractures, hip replacement, Parkinson's disease, back problems, and osteoarthritis. These are the exemplars we're going to be reviewing in NUR 200. So sit tight, put on your seatbelts, and let's roll. Okay, the concept of mobility doesn't really need a definition. It is what you think it is, and we'll just leave it at that. The objectives of this particular lesson are to be introduced to the idea of mobility, some of the overarching concepts related to it, do a concept review, and then a summary or a pre-summary of the exemplars that we're going to cover in class. Concept connection, you know I love it. Metabolism. Okay, metabolism in the bones creates osteoporosis. Osteoporosis creates fractures. So right there you have one of your connections. Okay, altered comfort, back problems, inflammation, sensory perception. I could go on and on and on and on, just depending on what sort of mobility issue you're dealing with. So the alterations of mobility, like I said, the exemplars covered in class: back problems, fractures, and complications of fractures. Traction goes along with fractures. We're going to look specifically at hip fractures and both surgical repair of a hip fracture and a hip replacement. We're going to look at osteoarthritis as a disease process. And finally, we're going to look at Parkinson's disease. Some of the factors that contribute to alterations in mobility are the things to think about: getting older, genetics. Some people just have more difficulty with musculoskeletal issues, obesity, physical activity or lack of it, and occupational problems. Some of the screenings and diagnostics that are common to mobility problems are X-rays, CAT scans, and then some labs. Alkaline phosphatase is a hormone that's released with a lot of breakdown of calcium. Sorry, it's not a hormone. It is a enzyme that's released when you have a lot of bone breakdown. So a high alkaline phosphatase level indicates you've had a lot of bone activity or metabolic bone problems. Serum calcium speaks to whether or not the calcium is in the bones or the calcium is not in the bones. Calcitonin and parathyroid hormone are both hormones that manage serum calcium levels and also have an effect upon the structure and function, or not the function, but the structure and strength of your bones. Creatine kinase. Creatine kinase is an enzyme that's released with muscle damage. So creatine kinase levels will be elevated when you have muscle problems. Uric acid is also, with cellular damage, is going to be released into the body. People with gout, which is a mobility problem, are going to have higher than normal uric acid levels, which is going to create a problem. When you're looking at nursing assessment and you're looking at mobility, you want to think about structure and function. Does it look like it's supposed to? And if you have a chance to see, is it functioning like it's supposed to? You want to look at the P's of adequate perfusion. The pain, the pallor, polar, all of those different things. You want to look at the client's history and their ability to do ADLs. Some of the components to a nursing assessment are also listed here: gait, posture, symmetry, spinal palpation, limbs, and muscle mass. The first exemplar we're going to cover is back problems, and we're going to talk about three distinct problems. One is muscular back problems, probably one of the most common things. We're going to talk about degenerative disc disease or herniated discs and surgical repair of such. And we're going to touch on scoliosis, kyphosis, mostly the scoliosis. Scoliosis we're just going to kind of do a drive-by on, but we want to at least kind of discuss it and make sure that everyone is on the same page with that particular disease process. So fractures. There are a lot of different types of bone fractures, and some are significant for certain things. So we're going to talk a little bit more about that as we move into the different types of fractures and their significance when it comes to what we're dealing with here. Some of the things we're going to look at with fractures, manifestations and treatment. Okay, there's first aid, so it's kind of that first thing you do when you sustain a fracture or a extremity musculoskeletal injury. We're going to look at the idea of traction and what's involved with traction, and then we're going to look at surgery or surgical stabilization of a fracture, also known as an open reduction internal fixation or an ORIF. And that's where you see all these nice little pins in this person's, looks like their forearm. Some of the complications of fractures that we're going to examine, one of them is compartment syndrome, which you should read up on and be familiar with. One is fat embolus. Now, we've talked about pulmonary emboli. This is a specific type of pulmonary embolus related to long bone fractures. And then deep vein thrombosis, which is a complication of immobility. And when you have a fracture, you do suffer some immobility, and you have to worry about whether or not someone is at risk for developing a DVT. With hip fractures, you have to think about what the biggest risk factor is. And it's, besides age, what's the biggest risk factor? Why is it a problem? We're going to look at the clinical manifestations and talk about the measures that are out in the community for safety and prevention, as well as things you should be teaching to patients that are at high risk for falls, and what things they can do to prevent the potential for a fall and a hip fracture. There's different types of hip fractures, which we will look at in class. There's a couple different ways to look at treatment of fractures. The short-term treatment is immobilization and traction. And then this patient usually needs to have some sort of surgical repair or replacement. An internal fixation will repair it if it's repairable, or sometimes they go ahead and replace the ball and socket that are part of the hip joint. The second exemplar, or one of the exemplars, is osteoarthritis. Okay. Different from rheumatoid arthritis because it doesn't have that immune component. And osteoarthritis is a disease of wear and tear. And it's wear and tear on those joints that you use every day. So the pathophysiology is going to be different from the pathophysiology of rheumatoid arthritis, and it's good to differentiate the two of them. There are different risk factors for osteoarthritis than there are for rheumatoid arthritis, and the manifestations are different. Treatments for osteoarthritis include surgery and a lot of pharmacology, as well as some alternate treatment. So surgery can include going in and cleaning up the joint. It could also include replacing the joint. And pharmacology includes things like NSAIDs. Tylenol is usually the first one. They try to stay away from the narcotics if they can. However, you may see muscle relaxants being used. You may see corticosteroids being used. Usually you need to have a multifactorial approach like is seen in this visual over here. So there may be alternative treatments like acupuncture, some emerging therapies, certainly chiropractic, braces, orthotics, and assistive devices. Weight loss will assist greatly as it relates to osteoarthritis. Exercise and physical therapy. So that's kind of that multifactorial, multimodal treatment that you look at for treatment of osteoarthritis. Finally, we're going to look at Parkinson's disease. And Parkinson's disease is kind of special because it is a mobility problem, but it's a neurological mobility problem. And it relates back to neurotransmitters. So much like MS relates to the transmission of nerve impulses along the nerve, this particular disorder relates to the nerve impulses communicating between neurons and their ability to move a message between neurons on neurotransmitters. And it involves the basal ganglia and the motor cortex, and it involves a lack of dopamine. So you can see on the right here you have what's normal, and then what happens when you lose your dopamine. And that you lose the ability to connect to the reticular formation, which is going to communicate with the spinal cord. Dopamine tends to be an inhibitory neurotransmitter, and so I think that's correct. You need to make sure that, without that ability to stabilize, you end up with some of the manifestations that we're going to look at here. Now, we all know some celebrities that have been diagnosed with Parkinson's disease, and we're going to look at them in a video in class. These are some of the more common signs and symptoms of Parkinson's disease. Things like bradykinesia, tremor, the pill-rolling tremor, that stooped posture, and along with that is the shuffling propulsive gait. And these are kind of classic signs and symptoms. So when you see that stooped over shuffling gait, that's Parkinson's. The pill-rolling tremor, the mask-like face. So this person looks like they've got a very flat affect, and it's just they have a blank expression. As well as the loss of control and ability to do voluntary movements. Treatment for Parkinson's, there are surgical treatment options, but a lot of what we're going to look at is pharmacologic treatment options. And we're going to be messing with neurotransmitters again. And certainly, it's good to know your neurotransmitters. So that concludes your basic concept overview for mobility. Before coming to class, I'm going to give you a break this time. Please complete the reading assignments and be ready to participate in class. As it stands right now, we do not have a pre-assignment. So please make sure that you are prepared when you come into class. Thanks a lot, and I'll see you in class.